So what we're going to cover in the next session is the whole topic of cotruncal anomalies. And for many of these, they are, in a sense, it's generally speaking straightforward in most in identifying aortic override, but then the next step is to work out what exactly the abnormality it is. And for us as a clinician, one of the real challenges is prognosticating and trying to get an idea of outcomes as we counsel parents, because the first question they're going to ask is, what does that mean for my baby? For all the talks, in a sense, that I'm giving, I will just say that there are some slides where I say facts and figures, and those facts and figures can be seen in any textbook, and I won't spend long on them, but they just contain key information for those who want to go back and have a look at it. So the talk, Tetralogía de Fallot, is divided into the following sections where I will cover facts and figures. I then go through sketches of cardiac abnormalities. Then after sketches, I'll then cover going through the types of Tetralogía de Fallot, from pulmonary stenosis through pulmonary atresia and then absent pulmonary valve syndrome. And then I'll talk about first semester diagnosis, differential diagnosis, and then outcome. And prenatally, it really should be the trilogy of Fallot, because right ventricular hypertrophy does not occur prenatally. So these are the three things which we pick prenatally, is the VSD, aortic override, and pulmonary stenosis. So just going through the facts and figures with regard to Tetralogía de Fallot, I ask you the question, what do you think the detection rate is of this condition? What's the detection rate in your country, your hospital, or globally? What do you think the detection rates are? And it's interesting in this data, which is quite recent, from 2019, it just shows you how variable the detection rate is. And it's France, which is always right up there in terms of its detection rate of congenital heart disease. And at the bottom of the list, in parts of the US or Kansas, with detection rates of 10%, and somewhere in the middle, the US of Atlanta, around 40%. And the UK, I always like drawing comparison with the UK, being part of the Commonwealth in Australia, and a third of Tetralogía de Fallot are detected. So it's still, and I think that data, again, in first trimester is also supported by Iris Papageorgiou. It's not just a second trimester, it's also a first trimester problem, is that we are missing most of Tetralogía de Fallot. So there are highly variable detection. And you say, Simon, why would it be different in one country when compared to the next, when many of us are working with similar healthcare systems and similar technologies, at least certainly in Europe? And I think a lot of it boils down to is actually having a protocol and making sure that you do a 5-section analysis. Because if you stick to a protocol, I think, in a sense, your detection rates will increase. And again, there's data to absolutely support that comment. A 5-section analysis, the dedicated third section, looking at the left ventricular outflow tract for aortic override, I think you will pick up Fallows. As an obstetrician, I think of Fallows as a condition, two types of Fallows. I think of Fallows as a pink Fallows, and I think of a blue Fallows. I think of a pink Fallows as a baby where you make the antenatal diagnosis, they have pulmonary stenosis, the babies are born, you check them after birth for any desaturation, and they go home. And they go home and they come back in 5 to 6 months and they have a single operation repair. I think pink Fallows is a condition which carries an excellent prognosis. Blue Fallows is not so good, particularly for the Fallows with pulmonary atresia. And for many of these babies who can't avail of operation, the mortality statistics are high. So in a sense, as an obstetrician, looking at babies with Fallows, I sort of, in my own mind, I have asked myself the first question, am I looking at a pink Fallows or a blue Fallows? And I guess I'm asking myself that question prenatally. One aspect about Fallows that I know is that the first thing or second thing I think of is Fallows. These babies are associated with genetic problems, and they're associated with structural abnormality, a third for each of those categories. So it's one of those cardiac abnormalities, unlike transposition of the great arteries, that the first thing I do is to say, what was the NIPT? The second thing is I'm sharpening my needle for an amniocentesis. Because when I look at the genetics, 30% of these will have the trisomies, 10 to 15% will be microdeletions, of which most will be 22q, And in the new world of exome sequencing, which Fatima covered so nicely, she made absolutely the relevance of exome sequencing and how that's playing a new role in genetic diagnosis. And I certainly know there are centers now routinely offering exome sequencing even for isolated fellows. Remember, in terms of once you make a diagnosis of fellows, go looking to see if there's any evidence of an associated abnormality. We make most of our diagnosis in the first trimester. We offer CVS. We don't do 5, we do a 6-probe FISH with 22q. We don't do exomes in Australia, but I feel that's around the corner. Unless it's Fallows that's syndromic. Then, yes, we do exome sequencing. We do a fetal echocardiogram. We Z-score the main pulmonary arteries and the aorta. And then we look for the evolution of markers of other problems. And then we continue surveillance until the 3rd trimester of pregnancy, making a decision where the babies are delivered. Australia is a big country, and there are babies who are miles away, and we have to make a call. Are we going to transfer that mother and her family and her children and the support group from where she lives to Melbourne and sit her there for weeks until the time comes when we deliver the baby and manage the baby afterwards? We are left with these practical problems. So we as obstetricians have to know, in a sense, which is the pink fallows, which is the blue fallows, and that, in a sense, becomes part of our duty of care. I found it hard in the prenatal literature to find data to tell me what percentage of babies prenatally progress from pulmonary stenosis to pulmonary atresia. Because as I said, right ventricular hypertrophy and infundibular hypertrophy and right ventricular outflow tract obstruction is a thing that happens postnatally because the pressures are equal in the fetal circulation left and right side, and it's that discordance and pressure in a sense the right side that drives the changes, pathophysiological changes of fallows after birth. There's very little data out there, and it ranged from 18 to 25% on old data, which I felt were really Lisa Horenberger and Pepis, a study from 2003, but they're over 20 years ago. I think this is probably the best paper of all for what I can read in the published literature, which is far more recent. And it's a single 18-year experience from a tertiary fetal cardiology center. And the chances of a baby going from pulmonary stenosis to pulmonary atresia is extremely small. And out of, you look at these, all of these babies, there were only 4 cases that actually presented with, at the end of the day, a functional pulmonary atresia. They had pulmonary arteries to start with, but there was progressive narrowing. So it's a very small percentage, and I guess that's important to know. That doesn't mean you don't need to continue surveillance of these babies. We need to continue surveillance. So I look at fallows and I say, these are the pink fallows, and these are the blue fallows, the pulmonary atresia. And then the very rare is the absent pulmonary valve syndrome. So in terms of cardiac sketches, I think it's always helpful to have sketches just to go through in your own mind, how do things look. So many babies with Tetralogía of Fallot will be completely normal in a 4th chamber. You won't see anything. The more experienced operator, you will pick up that there's a ventricular septal defect, or you may pick up there's a right aortic arch, which is in about 25%. And when you see a right aortic arch, it is more likely to be pulmonary atresia, so just bear that in mind. And then axis deviation is the other marker, which may be also a clue. And seeing axis deviation with a right aortic arch, especially in the first trimester, is what brings us to a diagnosis. When you look at the left ventricular outflow tract, it may be extremely subtle. All you may see is a tiny area of dropout, or you may find it just as a very subtle aortic override. And you're trying to make up your mind, is this just a VSD or is this a fallows? And I'll go through that. You may recognize that this has got a nice swan neck appearance to the aorta as it leaves, but in fallows it's more likely to have a straight course. And then especially in the first trimester, when you look with 2D and also especially with stick on 2D, you will see this turbulent flow because the aorta has been fed, in a sense, by both ventricles. So you've got a hyperdynamic flow. And then when you look at the 3-vessel view, and in fact, I should have said this at the very beginning, is that Tetralogía of Fallot, everything to do with Tetralogía of Fallot, the diagnosis, the classification, the management, the outcomes, all is based on the pulmonary artery. It's all focused on what does the pulmonary artery look like and how does it progress. You may have mild pulmonary stenosis, you may have moderate pulmonary stenosis, pulmonary atresia, which is defined as no flow across the pulmonary valve, which can either be the pulmonary artery never developed in the first place, Or the pulmonary artery is there, but there's actually no flow across the valve. So one is a structural or infundibular obstruction, or the other one is a functional pulmonary atresia. And then there's absent pulmonary valve syndrome. And these are the percentages. So most fellows, thankfully, fall into this group, and they're the ones that we're most used to seeing. When there is pulmonary atresia, you always ask yourself the question that the lungs demand a blood supply, so where do they get their blood supply from? And there are many different routes, and in a sense, this is when we're slipping into the blue fallows. When we look at the three-vessel tracheal view, this would be the most common scenario. We see a small duct because the vessel close to the trachea is the transverse aortic arch, so we know exactly where we need to look for reversal of flow by that rule. In this case, reversal of flow, so this is a duct dependent going back to feed the native pulmonary arteries. You may also see in 15% of fellows with a bilateral SVC. Or be careful with the right aortic arch with tetralogy of Fallot, because the duct may be present, but it sits right underneath the dilated aorta. So just remember to look in that space. Again, the importance of knowing where vessels are. And this is when it becomes complicated. So this is in the babies, in a sense, who have pulmonary atresia, and in a sense you want to know is where are the lungs getting their blood supply. And for most of these, it comes out the aorta, down the duct, and then feeds the pulmonary arteries. Nothing is coming out of the right ventricle. And in this case here, we have in all of these native pulmonary arteries, but they're getting feeds from different strange vessels, descending aorta, subclavians. But at the end of the day, from a surgeon operating on this baby, he wants to create a shunt between the right ventricle and the native pulmonary arteries. So they are a much easier group to deal with than this group down here, who have multiple tiny vessels but no native pulmonary arteries. So that's extremely challenging, and they're the blue fallows that do extremely poorly. That diagram is very important in understanding tetralogy of Fallot, who are the complicated group, because these are the group, in a sense, that we need to be mindful of when we're scanning prenatally. Okay, so you go to work tomorrow morning, and you start off by scanning this baby, the left ventricular outflow tract, and the first thing that strikes you is you see that there's a ventricular septal defect, dropout, edge enhancement, wash of color. The three criteria you use to make the diagnosis of a VSD. And when you look at the flow, bidirectional across the defect. So you're asking yourself the question, is this a perimembranous VSD, or is this tetralogy of Fallot? The answer to that question is you move from looking at the VSD to looking at the outflow tract. And as soon as you do that, you see that the pulmonary artery is larger than the aorta, is larger than the SVC. So in a sense, you say this to me is probably a perimembranous VSD, but it may evolve into a tetralogy of Fallot as the pregnancy progresses. In a sense, these are a little bit challenging, because you need to ask yourself, is there grounds here to step in and needle the pregnancy and investigate, is there grounds to do exome sequencing? Just let me check. I think I skipped a. Okay. So then we go to the next, which is the mild pulmonary stenosis. So in this case here, I think it's a little bit easier to turn around and say, I can see there's a VSD present, and I think there is malalignment of this VSD. But still, when you go to this, you see that the pulmonary artery is larger than the aorta, but there is something slightly different when you look at the aorta. You see that yin-yang appearance, which you see in Fallows with that dilated aorta when compared to the pulmonary artery. While the pulmonary artery may be bigger at the level of the free wall of the right ventricle, at the pure three-vessel view, it's slightly smaller. I'm far more suspicious now in this baby as having tetralogy of Fallot versus not. This one here, when I looked at it, I'd say, yeah, there's aortic override for sure. This is heading up to 50% aortic override. But I was surprised when I went to look at I see the trouser leg appearance here of the left ventricular outflow tract. I was surprised when I look at the right ventricular outflow tract that the pulmonary artery is actually a very good size. As I do so, I want to know, is there any aliasing across the pulmonary valve, because many of these babies will have pulmonary stenosis. And if it's just a malaligned VSD, it's more likely that pulmonary velocities are normal. But again, I'm just showing you examples one after the other of how challenging these babies can be. But now I know you're all in the room absolutely convinced about this baby, who starts off showing a normal four-chamber. And when you look at that labeled diagram, you can see that aorta is sitting 50% across. There's no dispute. But you still say, Simon, The pulmonary artery, when I look at it, is still a decent size, but I turn around and say to you, yes, but the pulmonary valve is not. That's the aortic, and you transfer it to the pulmonary. You hear the difference. You hear the then you swap over to the pulmonary, you hear choice. That Doppler comparison, simply listen again. Hear the difference in the sound? Before we even measure the centimeters per second, by simply directly comparing one against the other, while the three-vessel tracheal view in color looks normal, while there's convincing aortic override, I now have velocities that are more than the 100 centimeter rule. For me, I'm making a call on this baby, not having a perimembranous VSD. I'm making a call on this baby having Tetralogía of Fallot. And as we look at this case here, aortic override, dropout, edge enhancement, wash of color across it, turbulent flow, which I made reference to earlier on. This is the critical view. When I spoke in golden rule number 9, I'll be getting the short axis view showing the tricuspid valve, right ventricle, pulmonary valve, because it's out here is the outflow tract septum where you see your defect. But the most important thing here on this short axis view is you're looking for a band of muscle tissue where you get your infundibular hyperplasia obstructing your right ventricular outflow tract. That is a very important view, and I made comment about that earlier. And then the next step is to Doppler that. And so I Doppler the aorta. These are the velocities on the aorta, and I Doppler, these are the velocities on the pulmonary artery. These, however, are the cases that we're all familiar with. I've just shown you a list of challenging ones. Nobody will dispute a diagnosis of Tetralogía of Fallot, and you can see I'm Z-scoring the main pulmonary artery, I'm Z-scoring the branch pulmonary artery, and I'm Z-scoring the aorta in a baby who's 24 weeks of gestation. You can see that there's aortic override, there's dropout, edge enhancement. The aorta is less than 50% across, and therefore it's a Fallot's, not a double outlet. As you sweep, you see the free wall of the right ventricle, you see the pulmonary valve, you can see very clearly the pulmonary artery, and you can see the branch pulmonary artery, and that's smaller. You then pulse Doppler, the pulmonary valve. Most of these babies, they have a degree of pulmonary valvular stenosis. If it's just there's no valvular stenosis infundibular, it's more likely that your velocities will be normal. And when you come up to the three-vessel view, I'll talk about this in the first trimester, but you see the abnormal configuration of the arterial duct as it joins the inferior surface of the aorta, producing a Y configuration where the pulmonary artery is smaller than the dilated aorta. And then on stick, moving to stick, which we spoke about this morning, the beauty about this is it just gives you that precision of the imaging, showing the narrowed pulmonary artery where you can see that turbulent flow across the pulmonary valve. You can Z-score the branch pulmonary arteries with accuracy. This is a baby with Tetralogía of Fallot with pulmonary stenosis. And if you go back to the data that I showed you early, these babies are likely to continue with good-sized pulmonary arteries for the rest of the pregnancy. But I do need to do a short axis, and I'm worried anytime I see that band of tissue there obstructing the right ventricular outflow tract on a short axis view, because this here is my outflow tract obstruction, my subpulmonary VSD. In this case here, I'm just showing a technical point. Again, common to see small amount of fluid around the right ventricle as we did this morning. See the left ventricular outflow tract. I go to a slightly short axis view, sometimes a nice way of demonstrating that aortic override. But I just want to show you, in this case, I've chosen power. I've chosen power because the velocities are lower. I'm also showing you slow flow. As I use slow flow, you get this terrible interference, but then once you turn down your balance, you get that nice clarity and definition of your branch pulmonary arteries in a baby Tetralogía of Fallot with a moderate degree of pulmonary stenosis. So we will Z-score these, and we will follow these through the pregnancy. In fact, why many, many years of scanning babies to Tetralogía of Fallot, I didn't appreciate this Y configuration of the three-vessel tracheal view, because the normal three-vessel tracheal view should look like so. And this looks like the letter Y. That's why it's called the Y sign. But it's a super powerful marker in the first trimester of pregnancy for Tetralogía of Fallot. We next move into the group of pulmonary atresia. These are the group we all worry about with Fallots. And in a sense, I made the comment that untreated, 50% of these are dead by 1 year and 80% of these are dead by 10 years. If you look in the sense, the operation, they're far more challenging in terms of the repair of these. But in counseling patients, if you look at the published data on outcome of these babies, they require on average 8.1 interventions per patient compared to 2.8 for classic. And the reason being is the need to create a shunt between the right ventricle, and assuming there are native pulmonary arteries, as the baby grows, the heart grows, and the shunt doesn't, and therefore they have a minimum of 4 to 5 shunt replacements. It's complicated. Graphics, left axis deviation, right aortic arch, atrial septal defect, and the aorta will be much bigger. Makes sense, right? There's no flow to the pulmonary circulation coming from the right ventricle, and therefore it's all going to the aorta. So you're going to have a really big aorta, and you're going to see nothing coming out of the right ventricle. This diagram is important to understand. So the blood that basically comes out of the left ventricle goes down the aorta, and in a reverse direction goes up the duct, and that's how the lungs get their blood supply. That's why these babies crash after delivery, because once that duct closes, that supply of blood from the left ventricle goes and the babies crash. So in a sense, having that duct present and connection at the left side is so important. This is a case, however, where there's no duct, which represents 80% of them, and then there's these really worrying group where the collaterals solely come off the descending aorta. So how does it look? Well, you first of all look at the four-chamber view of heart. You see the perimembranous VSD, you see the aortic override, and you see the aortic valve. You do a split image, you demonstrate with color on the left. As you sweep up to the three-vessel tracheal, you know exactly where to look, because you look here is the aorta, and then right here is the reversal flow on the transverse aortic arch. Remember, the vessel closest to the trachea is the transverse aortic arch. So you know exactly where to look for at this point here for reversal of flow. You then switch to a sagittal image. You have the aortic arch, and then you have the reverse flow on a sagittal image. The lungs demand a supply. For this baby, it's got native pulmonary arteries to work on. In this case here, you sweep from a four-chamber view up to the three-vessel tracheal view. Again, if it's ever right aortic arch, I say to you, look underneath the aorta to find the duct. And if you can't see it, then remember, go to sagittal. Quite frequently, sagittal, some of these have really serpiginous vessels as they track, especially late in pregnancy, and they can be an interesting group to stick volume analyze. If you can't see a duct, then you're in this 8% group, which carry really poor prognosis. And how you identify these is you go to a four-chamber view of heart, and you look for the collaterals coming directly off the descending aorta. Collaterals can come off many different vessels. I mentioned also the subclavian. And then this is a first trimester case where you see the collaterals coming off the descending aorta with that big trumpet-like dilatation of the aorta, which you get in fellows with pulmonary atresia. And then there's the last group, is Tetralogía de Fallot with absent pulmonary valve syndrome, a very rare abnormality, but an abnormality we pick up in the first trimester of pregnancy. This is a patient who I scanned just very recently in Saigon, 24 weeks of gestation. So when you look at this, you see the turbulent flow across the pulmonary valve. And what you see when you look at that pulmonary valve is that bidirectional flow. You can hear the sound is equal on both sides as you get that velocity of seesaw motion. It's not actually the main pulmonary artery that's dilated, it's the branch. So it's the narrowing of the dysplastic pulmonary valve, and then the acceleration of the velocities blows high velocity flow into the branch PAs. And that's why the main pulmonary artery is not necessarily dilated. Sometimes they can look like an aneurysm of the left atrium as you sweep up to the three-vessel view, and then you see these grossly dilated branch pulmonary arteries. Important in a sense to look at these because this is the trachea and it's the right pulmonary artery that's closest to the trachea, and you want to see if there's any evidence of tracheomalacia. There is actually no published data prenatally, there is postnatally, but if you rotate on your three-vessel tracheal view and follow your trachea, you can then track the trachea all the way down and see if there's any narrowing or compression prenatally, but nobody has published on that to date. As I say, that narrowing has really only been looked at with the MRI. With regard to first trimester diagnosis, 13 weeks of gestation, you sweep from a four-chamber view of heart, and then you come up to there's the trouser leg appearance of the aorta overriding, and then you come up to the three-vessel tracheal view, and then look at this vessel. You see equal volume of forward and reversal flow. I believe absent pulmonary valve syndrome is really an abnormality that should be detected in all cases in the first trimester, and the published data supports that, and I'll talk about it tomorrow. A case going back from many years ago, over 15 years ago, left axis deviation, branch pulmonary arteries are not dilated. In fact, both of these cases, there's very little dilatation of the branch pulmonary arteries because it's only the first trimester. It's actually as the pregnancy progresses that you get that progressive dilatation. I talk about first semester Tetralogía of Fallot. As I say, for most of these, we pick these up in the first semester. But I ask you the question, say, Simon, how do you pick it up in the first semester? Because you started off your lecture by saying that you look at the left ventricular outflow tract and you see aortic override. Well, the left ventricular outflow tract is not part of the ISUOG guidelines in the first semester. The ISUOG guidelines make a recommendation in the first semester of showing a 4-chamber and a 3-vessel tracheal view. So how do we pick it up? Well, we can get information from the nuchal translucency. A nice paper was published by Leona Poon on this very early in pregnancy. Fallot's is one of the conditions that's got the highest chance of increased nuchal translucency in the first semester, unlike transposition of the great arteries, higher than most other conditions. Left axis deviation in the second image, Rabi and colleagues have published about left axis deviation as being a very powerful marker. The Y sign has been published as a very powerful marker in the first semester of pregnancy. The question mark sign has been published as a very popular marker. Tricuspid valve regurgitation, we don't do ductus venosus anymore. Not in the era of NIPT. It's too time-consuming, it's too challenging. Yes, tricuspid and all the others. All of these are markers that bring you to a diagnosis of Tetralogía of Fallot. If you look at cardiac axis deviation, it was first reported in 1995 by Ship and Horenberg in the second trimester, and then it was Ship, Rabi, and Alfred Abu-Hamid in 95, who then reported it as being a very powerful marker. Look how good it is when you look at it in terms of co-truncal abnormality that 80% of them or more will present. Really very, very helpful marker. So you go to work tomorrow morning. For every examination you do, golden rule number 5 or 6, whatever it is, you do a split image showing the stomach, and then you do a split image showing the 4-chamber beside it. When you compare one against the other, you appreciate that there's axis deviation. It's that important systematic approach for every examination that you do a split image, and then you instantly recognize that there's axis deviation present. The Y sign was a sensitivity of higher than axis deviation and a specificity of 99%. In fact, they made the comment that axis deviation only increased the false positive rate, making comment that the Y sign is actually a very powerful marker. I'm not saying you should do that and not do the other. They're all helpful. That's what a V sign looks like. That's what a Y sign looks like. And these are 6 cases of Tetralogía of Fallot, which I'll go through in a little bit more detail tomorrow as I talk about first semester. This was from Fatima's group and Gratikos's group, and a really nice paper looking at the question mark sign, Tetralogía of Fallot. And this is only for Tetralogía of Fallot with a left aortic arch. It's interestingly not present in, well, it makes sense in a sense, it's not with a right aortic arch. So if you're doing a left ventricular outflow tract and you see this sort of appearance at 13 weeks of gestation, you see that unusual course of the aorta in a baby with a question mark sign, or a transvaginal examination in this baby with pulmonary atresia, you can see the gross dilatation of the aorta, but the swinging of the aorta to the right, but it comes back to the left of the trachea. And then all of these signs ultimately bring you to look at the left ventricular outflow tract, to look for evidence of aortic override. And then once you see the aortic override, your next question is where is the pulmonary artery? You go to work tomorrow morning, none of these signs are there. You start off and you tell me what's going on here. You scan a baby who's got a thin nuchal translucency, a normal cerebral fourth ventricle, normal nasal bone. When you look at the stomach, you look up to the 4-chamber, there's no axis deviation. Next step is you move to looking with your color. And this is why the sonographers pick it. Because when they sweep from a 4-chamber up to the 3-vessel tracheal view, they see the Y sign. There's actually very little discordance between these great vessels. And then the next step, the patient comes across to me, and I use my friend's slow flow. I see the pulmonary veins entering to the left atrium, but watch what happens when I look up to the 3-vessel tracheal view. I see the azygos vein, and then I see the internal thoracics, but then I see the left brachiocephalic vein, and there's no thymus gland between the brachiocephalic vein and the sternum. So straight away, I'm on to this baby needs a chorion biopsy and needs a 22q probe analysis because this baby has got DeGeorge. With looking at the outflow, I want to know in terms of the left ventricular outflow tract. Again, I will use slow flow, plus or minus balance. I see the aortic override. The point I'm making is this baby is at 13 weeks of gestation. It looks absolutely no difference to making a diagnosis in a baby with Tetralogía of Fallot at the mid-trimester. In this new world of exome sequencing, where we know that there is a high yield of exomes in syndromic Tetralogía of Fallot, making this diagnosis is so important in the first trimester of pregnancy. And then I finish off examining this baby, looking at the question mark sign, which was where that image came from, and then I do a stick I acquire the volume. She's holding her breath for 15 seconds. I've got a very narrow angle. I've set my quality at max. I'm on power Doppler examination with the PRF of 25 to 35 centimeters a second, and I've acquired the volume. I end up with a multiplanar. I go to the A plane. I measure the heart. It's 9 millimeters by 10 from apex to base. I then go to sweep from the 4-chamber up to the 3-vessel. All the signs of Tetralogía de Fallot are demonstrated on a single stick volume. I then will move to VCI A plane, use wide slice, which will give me a 3-dimensional perspective of the Fallows at 13 weeks. And then the next step after that will move on to a rendered image. From there, I've made a diagnosis. It's a certain diagnosis as I can see it. And the next step is then to move offering patient chorion biopsy. When I say make a certain diagnosis, let me just reiterate, I do not make a certain diagnosis. I make a certain diagnosis with the pediatric cardiologist in the room. It's a very important point. For every single case that I show, in a sense, over the next 2 days, is shown in a sense that it's the experience of a pediatric cardiologist. We learn from each other, but ultimately it's the pediatric cardiologist who goes into the room with me and counsels these patients. And then the final icing on the cake is, remember, you can get pulmonary stenosis in the first trimester of pregnancy. It's not something that necessarily evolves over time. And what do? I do a pulse Doppler across the pulmonary, and I do a pulse Doppler across the aorta, and you can see they're double. The pulmonary velocities are higher. I finish up with differential diagnosis because I know this is going to be covered as we go through this. We will cover the most important one, I guess, is to common arterial trunk, which we'll be covering. Again, for most of these, a common arterial trunk, we will make these diagnoses in the first trimester because the aorta is so grossly dilated. And in a sense, the 3-vessel tracheal view is abnormal. And also the double outlet right ventricles in the first trimester of pregnancy. When we look at these, we see that there's axis deviation. But when we look at the left ventricular after tract, the aorta is coming predominantly out of the right ventricle. So this is a double outlet right ventricle with a subaortic VSD on the right side with the Y sign configuration. Be very careful. I can't tell you the amount of times I've had patients referred to me, Simon, Tetralogía de Fallot, please assess, consider chorion biopsy, or in the mid-trimester. Do you think this baby has got Tetralogía de Fallot? It is very easy to create an impression of the aorta looking astride when you go in an oblique 4-chamber or an oblique left ventricular after tract. This baby is completely normal. And I have to admit that I have, in my training and in my years of practice, made a call of Fallows in a baby that was completely normal after birth. I've learned my lessons. And I can also share with you on the 3-vessel tracheal view, this is much more common. You're nervous because the pulmonary artery is smaller than the aorta. You have to ask yourself the question, is the aorta dilated? And then you go to left ventricular after tract. That's a completely normal pregnancy. You do get discordance in the great vessels, not in the first trimester, in the second trimester. And lastly, this is a very recent patient. You can see an AV canal defect with Tetralogía de Fallot. Ever see that combination of pregnancy, it will almost certainly be trisomy 21. For us, however, in Australia, I knew it was trisomy 21 because she came with an NIPT, so I went straight to the heart. But in days gone by, it was the other way around. So I'll finish up with covering the genetics of it. And if you look at, I think one important paper to mention is Mary Norton's paper in the American Journal, is because there are patients who do not want genetic diagnosis. They don't want invasive genetic testing, that you have the option of cell-free DNA. And there's many of those that say, well, cell-free DNA is a waste of time, in a sense, for a microdeletion as small as 22q. Well, actually, the data does not support that argument. If you look at Mary Norton's data on it, is that the sensitivity, specificity, most importantly, the positive predictive value for a condition that has such a low prevalence. Remember, positive predictive value is determined primarily at what the prevalence of the condition is. The algorithms have got so damn good. So this is something, in a sense, in the future, in making a call of Fallows, is NIPT is something for patients who do not want invasive genetic testing. And in terms of when we look to exome sequencing, this is the specific data of exome sequencing relating to Tetralogía de Fallot. And look at those figures, a yield of the order of 23% for syndromic Fallows. That's a very high yield. And then there's the yield of the order of about 6 to 7% of those of non-syndromic Fallows. We may leave that for Q&A, because I don't know if making a call for isolated Fallows of these gene deletions is a good thing or a bad thing, and maybe I'll explain that when we come to Q&A. My last slides finish up with outcome. This is probably one of the most difficult areas to prepare a talk for because there's so much data out there and they're all saying different things. And in a sense, the prediction, when I say they're saying different things, they're looking at different things. Predicting fallows, whether it correlates with postnatal outcomes, whether it's going to be duct dependent, whether it's going to require early intervention, whether it's going to be a single operation pair of the baby, whether it's going to require a transannular patch, or what's the mortality of it. There is so much data. Let me simplify it. And I think if you look at it, the key things that have been looked at is the size of the pulmonary artery, Z scoring it, the reversal of flow along the arterial duct, and the velocities. I don't believe there's data enough to support velocities in predicting outcome. Yes, I think the data lies with Z scoring and reversal of flow along the arterial duct. For those who are maternal-fetal medicine fellows and your exams are coming up, I'll just make life easy for you, because these are all the key 15 core original papers with a barcode colouring of it to show you the studies looking at these particular interventions. But I do want to share with you just one paper, and that's a paper from Melbourne, a paper, multi-centre study from Australia, and looking at it in terms of the outcomes, it's actually 13% of these babies required early intervention with Tetralogía de Fallot, and in terms of planning, delivery, and arranging for a woman to come to a major centre is if the pulmonary valve Z score was less than 3.5 or the ductus venosus flow, there was reversal of flow. It did, however, make the important point. It becomes really challenging late in pregnancy trying to demonstrate the ductus arteriosus because in 25% they couldn't see them. So I will leave with one very final slide. There's a new world stepping into prenatal medicine, particularly with regard to cardiac disease, and it's the outcome of babies later in life. What does a baby look like when it's 30 years of age, having had a diagnosis of Tetralogía de Fallot? Is it really a single operation repair and they go home and they never need anything again? No, that's not the case. There's actually a whole discipline of adult congenital heart disease. Because if you look at it, the biggest problem with babies with Fallows is they end up with pulmonary regurgitation, right ventricular dilatation. And for these, they require surgery later in life. They end up with ventricular arrhythmias and sudden death is a significant risk. Ventricular dysfunction, they need pulmonary valve replacement. About 35 to 45% of them need intervention. It's not a cure in terms of surgery after. It's a lifelong disease that requires this surveillance throughout a child's life. I think it's important, and I need a sense to know this, but I need to be very careful, and the ethics, whether we convey this or not, is maybe another question for Q&A. I think I'm a little bit over time, so I'll just finish up with that slide with the 6 key take-home messages from my talk today. Thank you very much for your attention.